Healthcare is too expensive. Employers are offsetting costs onto their employees. Who will make health benefits affordable for hardworking Americans and their families? You will. This is the Empowering Plans Podcast, a show dedicated to helping you once again emphasize the benefit in benefit plan. Now prepare to learn, plan, save, and protect with the FIA Group.
Hello there, and welcome to the latest episode of the FIA Group's podcast, Empowering Plans. I'm John Jablon, and today Nick Bonds and I are going to be talking about mental health parity, specifically the non-quantitative treatment limitation analysis now required by the Consolidated Appropriations Act. There will be a lot of acronyms and long names of laws in this podcast. We will do our best to elaborate and try to use some basic acronyms. But in case you aren't familiar with it, the CAA, the Consolidated Appropriations Act, has created a new requirement for compliance with the Mental Health Parity and Addiction Equity Act, or MHPAEA, or really probably just Mental Health Parity Law for short. That requirement, of course, is to generate and submit a written analysis of the plan's NQTLs. NQTLs, as I said, are non-quantitative treatment limitations. Those are often not quite so straightforward to the average reader of a plan document. And so just to elaborate, an NQTL is some sort of limitation on benefits, really any kind of limitation, whether or not it is intuitively a limitation at all, which it's not easy to count or put some number on. So for instance, a 10% coinsurance is objectively more than a 0% coinsurance. There's no question about that. It's just math, right? 10 is more than 0. That's couldn't get simpler. Whereas for an example of a NQTL, one benefit being subject to pre-cert while another is not, it may still be easy to figure out which is a bigger limitation, but it's not quantifiable. So 10% is more than 0%, but pre-cert versus not pre-cert, it's not a number. You can't plug it into a calculator. You would get that NaN, that not a number result. And the reason that this is all important is, of course, that the federal mental health parity law has a parity requirement. The word parity is right in there. It prohibits a health plan from imposing stricter limitations on mental health or substance abuse disorder benefits than it does on medical and surgical benefits. So to use that quick example of a 10% coinsurance versus a 0% coinsurance, if a health plan were to say something very broad and sweeping, like mental health benefits are all subject to 10% coinsurance, while medical and surgical benefits are paid at 100%, 0% coinsurance. Well, that is a major parity violation because mental health benefits are subject to a major limitation that is greater than the limitation that applies to medical and surgical benefits. So I know that that's all a mouthful, but I hope it provides at least a decent introduction to what we're going to be talking about. If you have any clarifying questions after this podcast about the content or what the heck we're talking about, what an NQTL is, because I haven't explained it well, please feel free to reach out to FIA. So we are in the process and really just right in the thick of providing these NQTL analyses. It's one of the ways that we have really changed our business with the times, right? Because as laws change and as plans needs change, well, FIA changes as well. And that has always been the case. It's actually one of the things that we pride ourselves most on. So we are doing these NQTL analyses and we are getting fantastic firsthand views of what is really going on with the analyses. And of course, Nick is going to talk about this in a bit, but the regulatory bodies that are in charge of this were required to give a report to Congress. And that report is really, really interesting and very telling about the context of what is going on here. So I'm going to start to talk about some of the practical issues we have seen with these analyses and some of the barriers and some of the confusion related to them in the hopes that this is informational and maybe even instructive to many of you. And then Nick is going to talk about the report to Congress and lessons that we have learned and can continue to learn from the way the regulators are viewing this. A lot of it jives with how we're viewing it, but they've got more insight because they are seeing a lot of reports and doing summary stats based on them. So it's really interesting stuff. So for one thing, I mentioned before that NQTLs are not always quite so easy to see. Plan language, simply put, is not dispositive of whether or not a disparity exists. Plan language might look perfectly fine, and frankly, it might be perfectly fine. But the essence of an NQTL is that it is either written down or in practice. That's a huge, huge part of the analysis that a lot of people are overlooking. It's not just about plan language, because it's very easy to look at a plan and say, you know, this language is totally fine. We don't see any disparities here. All these NQTLs look the same. but it's just not that simple because you also have to look at what's going on in practice. So a great example, and I love using RBP or reference-based pricing as an example for everything. So many things, since in a lot of senses, RBP plans are the purest form of uniformity when it comes to a lot of things, most obviously payments. Right? If all providers are paid at one preset amount, what could be simpler than that for example purposes? Now, obviously, there are complexities in determining that amount, and then there's balance billing and all that jazz. But when the plan just says, no thanks, networks, we pay what we think is fair based on these criteria, other types of issues have one fewer variable to deal with, one fewer moving part. But I digress. So here's my example. An RBP plan says that all providers are out of network, right? There's no network, but the plan signs contracts with certain facilities to prevent balance billing, which is extremely common with reference-based pricing. The plan feels, however, that residential rehabs are too pricey and too unreasonable and refuses to contract with them. The result is that the plan member has a higher chance of being balance billed for a mental health or substance abuse claim than it does for a medical or surgical claim. Because with a medical or surgical claim, remember, the plan is giving the participant options for, let's call them safe harbor providers, providers that have contracts. Whereas for a large class of mental health and substance abuse claims, there is no such option. So obviously, it's not to say that this can't all be rectified pretty easily if the plan has a standing policy of negotiating all potential balance bills to, avoid balance billing, but it's still an NQTL, and it's the type of thing that needs to go into an analysis. It's funny, we've been getting a lot of questions regarding QPA calculation, right, under the No Surprises Act, and obviously this is another topic for another day, probably many other days, given the breadth of the topic. But if you're working with RBP plans that aren't sure whether they're bound by all these fun new laws, the easy short answer is, oh, yes, they are. And if you need help figuring all that out, please do not hesitate to contact us. But we've seen a bunch of RBP plans at this point saying, none of this really applies to us because we don't have any NQTLs. Well, maybe, but more likely you do, and they're just not so obvious.
Yeah, and John, I think I can interject a little bit there too. We've seen a lot of the plans that we work with sort of have this perception that I think just stems from sort of the conversation around NQTLs and how we're analyzing them and trying to ensure they're in parity. A lot of plans sort of have this perception that having any NQTL is bad and that the only way to be compliant is to not have an NQTL. And that can lead some groups, like in your example, to say, no, we don't have any NQTLs, we comply with mental health parity. But that's not actually the requirement. Having an NQTL is not in itself a problem. In fact, they're really key to how some plans are designed and how they contain costs. What's important is that those NQTLs are no more restrictive against the plan's mental health and substance use disorder benefits than they are against the plan's medical surgical benefits. And in fact, they don't even have to be identical. The plan, if it wants to, could be more generous in its NQTLs as they apply to the mental health side than to the medical surgical side. So a plan can actually have more restrictive limitations on its medical surgical benefits if it really wants to than on its mental health benefits and still be in compliance from a mental health parity perspective.
Thanks, Nick. You actually raised two really, really great points there. I shouldn't have said actually. You often raise great points, Nick. Thanks for your input. So the first point is that, like Nick was alluding to, the requirement is not to complete the analysis if you've got violations of the Mental Health Parity Act. The requirement is to generate the report. Well, period. You have to generate the report. Whether you have NQTLs or not is irrelevant to the requirement to do this analysis. So if your analysis comes back and whoever's performing it concludes, yeah, there are no NQLs here that unduly place limits on mental health or substance abuse claims more than medical or surgical claims, that just means you passed. But you still had to do it. You still have to document whether you passed or failed. I use those terms loosely, maybe a little sarcastically, but the requirement is to do the analysis. And the second point, and this just occurred to me while Nick was saying what he was saying, this is very comparable to a discussion we often have about fiduciary duties, in the sense that there's nothing inherently bad about having a fiduciary duty. It's just once you have that duty, you need to kind of watch out for how you use it. So an NQTL, a non-quantitative treatment limitation in itself, is not bad. It's only bad if it violates the Mental Health Parity Act, if it applies more stringently to mental health or substance abuse claims than it does to medical or surgical. So if you impose greater limitations on medical or surgical claims, that's still an NQTL. It just doesn't violate the mental health parity law. So I hope that all makes sense. So thanks, Nick. Great stuff. And another example of some things that is maybe not quite clear from the plan language, but that might or are NQTLs. We've seen a lot of continued confusion from many of our clients regarding provider concentration NQTLs. And what I mean by that is, for example, if there are many fewer in-network mental health or substance abuse providers than there are medical or surgical providers, it's obviously not written into the plan doc, right? Since it varies by network. And of course, networks can change all the time. So it would be insane to include all network providers within a plan doc. That's just not done. But for instance, if there's one in-network provider choice in the area for mental health or substance abuse claims versus 10 in-network choices in the area for medical or surgical claims, that's probably going to be an NQTL because the provider makeup, the provider concentration is vastly different. And of course, like I said, that varies by network. And that's, of course, also going to depend heavily on the current network makeup and the network directory. And it's just not always easy to kind of plot those on a map and try to figure out all the stats. But often networks will be able to provide you some sort of summary information that details this in a readable way. But just know that even stuff like that, even stuff that would never in a million years be written into the plan document, it can still be an NQTL because it's in practice rather than in writing necessarily. And additional factors with the provider concentration NQTL include stuff like geographical location of the providers, whether there are direct contracts with certain providers, employee incentives, and just generally other things that may impact how many or which providers are or effectively are in network. And then, of course, at the other end of the spectrum, we've seen a lot of plans with language that seems non-compliant. We look at it and we just think, at first blush, oh, that doesn't look good. But upon further review, it actually seems fine. It just goes to show that plan language is not at all dispositive of whether NQTLs exist, because sometimes it looks like they do and they don't. Sometimes it looks like they don't, but they actually do. And then another fun issue we've seen, and this is where we're having a bit of trouble navigating this in some cases, just because it's not always so straightforward, and you'll see what I mean once I actually talk about it. A lot of plan documents we've seen have language that the TPA just ignores because the TPA knows it's not compliant or knows that it's not practical. And the lesson we learned from that, obviously there are NQTL concerns, right? Because if there's an NQTL in writing, but not in practice, well, that makes the analysis just a little bit more interesting than it would otherwise be. But just note that, like always, right, plan documents need to be updated to reflect what plans are actually doing. It's not about what you say versus what you do. It should be about what you say and what you do, because those are supposed to be the same thing. And that's not even just Parity, right? That's ERISA. ERISA says, whatever you're going to do, write it down in the plan doc. When we see issues where the plan doc says one thing, but the TPA knows better than to follow that, and the TPA does another thing, well, I mean, on the one hand, it's great that the TPA is not violating the law by applying non-compliant plan language, but at the same time, we can't help but wonder, why hasn't the plan document been updated? Do it as soon as you can. With that, I am going to transition away from a discussion of what the NQTLs actually entail, and now I'm going to talk about a couple of specific issues we've seen with the provision of data or general things like that. So for one thing, and I'll keep this short, but a lot of state ASO licensees apparently are not able to provide operational utilization management data, even though they are the ones that provide the UM services. And that's a little bit baffling, right? Because if they're the ones providing the services, why can they not provide even summary operational data? I don't know. It's a great question. I wish I could answer it. But generally, if the vendors are unwilling or unable or whatever, you don't get it. If you don't get the information from the vendor, what we recommend is that the analysis calls that out. You can't just do an analysis and gloss over certain things because you don't have the data. You've got to talk about the fact that you don't have the data and maybe even an explanation of why. The exact way that that can be described in there is a bit discretionary, but at the end of the day, there are certain specific requirements in the analysis, and we certainly don't recommend ignoring any of them because you haven't been able to get data from vendors. And another option, of course, if you're using a vendor that is unable to meet your compliance obligations, turn conversation might be in order, or maybe even look into other vendors. And then another practical issue we've seen, and this is a really interesting one that ties into a lot of other aspects of our business as well, some groups have requested an analysis performed based on a recently amended version of the plan, which has since fixed its NQTLs. The idea being, after this law was passed, we made changes to the plan, we got rid of our NQTLs. Can you analyze this version of the plan? Well, that's great for next year, but the analysis is supposed to cover the previous year, not the next year. So If you just amended your plan during the last year, it was not amended in this way. And so we really don't recommend only doing an analysis of what's effectively a future plan. We recommend analyzing the plan over the past year, which is what is required by the law. And that goes to the topic generally of retroactive amendments. They're typically ineffective for benefits because, of course, the SPD is a contract, right? And you can't just pretend it used to say something different from what it actually said. You can amend it moving forward, but the benefits that were in the plan at the time of whatever is happening, right? At the time a claim was incurred, at the time it is required to have an NQTL analysis, whatever that point in time is, that's what the plan says at that time. There's lots more I could talk about here, and we could probably do 5 podcasts on this. But in order to keep this to a time that makes sense for everyone, I'm going to stop here and I'm going to turn it over to Nick, and I'm going to take a sip of water. But Nick is going to talk about the department's 2022 joint report to Congress. Take it away, Nick.
Thanks, John. I think all the things you pointed out there, that makes a lot of sense. And I think, again, we'll just reiterate that if any of that was confusing or if anybody out there listening has any other questions about the mental health parity law, please reach out. We're here to help. But one of the big things that just came out here at the end of January was the DOL and HHS and the Treasury Department's joint report to Congress, sort of explaining their past year of mental health parity law enforcement and all of the comparative analyses that they've requested and looked at. And it's interesting, this is really good timing for this report, actually, because it's effectively been almost exactly a year now of the comparative analysis requirement being in effect. It was implemented as part of the Consolidated Appropriations Act of 2021, which actually became law at the very tail end of 2020. But the requirement to perform the comparative analysis actually took effect February 10th. So we're coming right up on the 1-year anniversary, a year with the comparative analysis, basically. And so the big highlights from the report, the DOL and the joint departments were sort of talking about, they're laying out the hard numbers of what they've done to enforce the rule. They've sent out 156 letters requesting comparative analyses, been analyzing, they call it 216 NQTLs. Now, I'm not sure exactly how they're counting, if they just mean literally there were 216 discrete NQTLs that they have on a list that they were analyzing, or if that's just the number of NQTLs that span those analyses. But suffice to say, there are a lot of potential NQTLs that can apply to any plan. And like John was saying, we see them pop up in all sorts of places when we're looking at plan documents, when we're looking at how these plans are designed and how some of their programs are implemented. But of those 156 letters, the DOL sent out 80 insufficiency letters. The DOL goes on to say essentially no one in their initial comparative analysis had a sufficient analysis performed, but at least 80 of those on subsequent review were deemed insufficient. And they've sent all kinds of communications to plans out there, kind of going above and beyond what the law actually required them to do. Under the Consolidated Appropriations Act, the DOL only had to reach out to, I think it was 20 plans to prepare this report to Congress. So they've really, really gone above and beyond to try to enforce this requirement and prepare as much data for Congress as they can. But I think some of the big takeaways from the congressional report is essentially the departments are pretty disappointed in what they saw from mental health parity compliance with most of the groups that they looked at. They highlighted kind of overarching themes of a lot of the analyses that they looked at. And one of the big things that they complained of, which probably shouldn't be too shocking, but the DOL seems to have just been completely flummoxed that no groups had been preparing these comparative analyses before, which is interesting. Technically, under the mental health parity law, a comparative analysis was a requirement, but it wasn't until the Consolidated Appropriations Act that comparative analysis was required to be written and then provided upon request. So in theory, this should have been something plans had done in the past. They just maybe hadn't written it down. But the DOL essentially found that most groups hadn't been preparing a written analysis, and beyond that, hadn't even started preparing a new comparative analysis until they received a letter requesting it from the DOL, which, given the sheer volume of information that we've seen goes into preparing these, by the time you get a letter from the DOL, you are very, very behind in the preparation game. A couple of other things, like John, you and I have both worked on analyses where we've been sort of under the gun of a DOL audit request, and it is not a fun place to be for anybody.
No, although I will say that they have not been terribly unreasonable with granting some extensions. That's nice, at least. I mean, there was one, what was it? It was due like Christmas Eve by midnight. And it was just like, Oh, you're going to read it on Christmas? Okay, maybe give us another.
Right, right. That is worth pointing out that the EDSA and the DOL have been really good about responding to requests for extensions. That's actually one thing that they complained about in the report, is that almost all the plans they reached out to were requesting extensions in time. But I mean, it makes sense. Even if you have a report kind of ready to go, I think a lot of groups just sort of as a matter of when they're corresponding with the DOL might ask for more time to comply with a lot of their requirements. But the DOL also highlighted a couple of things they didn't like. This one was a little odd to me. They specifically seemed to complain about plans that their analysis was essentially two columns. They would make a chart, they would have a column for medical, surgical, and then a column for mental health and substance use disorder benefits. And they would just list their NQTLs and say whether they were comparable. And I can kind of see why the DOL would not consider that satisfactory. Our analyses that we've worked on, that we've prepared, they incorporate a little bit of that. I mean, it's just an intuitive way to analyze your benefits when you literally have two things you need to compare. But one of the steps that we take to go sort of beyond that is not only comparing the NQTLs and the factors and the evidence that applies to each NQTL in a chart, but we also narratively dissect every single NQTL, the plan language that outlines it, or the vendor program that outlines the NQTL, and describe in clear written language how that NQTL applies, whether or not it's in parity, and why. And I think that that's actually more in line with what the DOL is looking at. They don't want conclusory statements. They don't want just a mess of data and a plan saying Scouts Honor, we're compliant. They want you to make it as easy as possible for them to follow through the design and application of an NQTL and how it's actually operating within the guardrails of mental health parity laws. But also, I think that, John, you maybe got a sense of this too, that the DOL's complaints about the comparative analysis don't necessarily take into account how most self-funded plans are designed. From the big carrier side of things, it makes sense that there would be sort of a documented process of implementing certain plan designs, and these are the reasons why these limitations exist. But for a self-funded plan, especially a small self-funded plan that's maybe existed for a while, they may not have that kind of institutional memory or that kind of documentation of why every single NQTL they currently have in effect was created. The people who helped write and design the plan originally probably, in a lot of cases, may not work there. They may not have, the resources or the data to go back and show, hey, this is why this exists. And I think that's something a lot of plans have struggled with in trying to put together these analyses. And that's one of the things that we try to get at in our work preparing these, is we try to help plans see that they need to do a little bit of legwork, essentially. NQTLs that plans have in place, they need to be able to explain that NQTL, why it's been implemented, what evidence they relied on to implement it. And I think that plans would be well situated if they could make that sort of a standard practice going forward anytime they are contemplating a new NQTL or a new plan limitation of some kind, just to make sure that they have something written down that they can point to in case the DOL does come knocking, to say, this is why we put this limitation in place, this is what we relied on to justify that limitation. There's just so much detail that the DOL is looking for, that the more steps the plan can take to sort of lay out its rationale for why it's imposing these limitations, the better off they'll be down the line.
Yeah, from a practical perspective, a lot of plans, if asked the question of, why does your plan language say this? Why do you have this limitation? They would have absolutely no idea, right? I mean, for one thing, the plan doesn't usually draft the plan document, but the TPA or some vendor. And for another thing, so many plan docs are based on a template. Like the plan's answer,
right.
If it would say, well, I don't know, I bought a template. I filled in the benefit percentages and the rest I thought was standard. And that's not a bad answer. It's just not the full answer that the DOL is looking for. So like Nick said, if you've got questions, we can try to help brainstorm, but ultimately whoever drafted the plan may have a better answer for that.
Yeah, absolutely. And I think another big takeaway from the DOL's report, to sort of pivot to where the DOL and the departments enforcing the MHPAEA, the mental health parity law, sort of where they're going. At the very end of the report, they listed a few things they're specifically asking from Congress. They basically had a wish list of things they want Congress to do that would basically give the agencies a little more teeth, that would give the mental health parity law. It would heighten the stakes effectively for noncompliance. So one of the main things that the DOL asked for would be the authority to assess penalties. They want to be able to specifically assess civil penalties for any parity violations. And this sort of mirrors what the DOL does to enforce ERISA. If they see violations of ERISA, they can assess penalties, and they sort of want that parallel authority on the mental health parity side, which would probably scare a lot of plans if they knew that they could not only have the potential of an individual member complain under the mental health parity law and sue for benefits, but if the DOL itself can come down trying to enforce the mental health parity law with the potential of fines, that's a big deal, and that's a really big change that plans need to look out for. Another big thing that the report called for was the EDSA, the Employee Benefits Security Administration. They're sort of the sub-DOL agency that is charged with really the on-the-ground enforcement efforts. They want to be able to expand their jurisdiction to regulate TPAs and some of the vendors that work directly with these ERISA self-funded plans, which, again, that would be a big shakeup to the industry and something that a lot of the players we work with need to keep an eye out for. There's also a few other things that are kind of interesting. The report wanted Congress to sort of look at ways of expanding access to telehealth, by which they seem to literally mean they were hoping for Congress to expand access to like broadband and to make internet a little more easily accessible to like rural parts of the country, which would be beneficial for a lot of things, but the idea of expanding access to telehealth through literally laying a fiber optic cable would be really interesting. And then another thing, the DOL wants Congress to sort of limit the latitude that plans have for determining whether services are qualified as medical surgical services or mental health benefits. They want to sort of tether that to external standards. So basically the DOL wants Congress to say essentially that if the DSM-5, if the Diagnostic Statistical Manual deems something a mental health benefit or a substance use disorder benefit, then plans have to follow that guidance, which again would kind of limit the flexibility that self-funded plans have. But in the DOL's eyes, it's something that's kind of necessary. So we'll see if Congress takes them up on any of that and what, if any of that, could potentially pass. But those are definitely some big changes in the mental health parity space for plans and for vendors to keep an eye out for.
Well, thank you so much, Nick. That's all great information. We're going to wrap up now. And if you've got other questions, please do not hesitate to reach out to the FIA Group, pgcreferral@fiagroup.com. Or if you are a client of our ICE service, just contact your designated representative. Thank you so much for listening, and we hope to see you on the next episode of this Empowering Plans podcast. I am John Jablon. That was Nick Bonds. Thanks so much for listening. Take care.
Thanks.